Hi everyone, my name is Haihley Connors. I am a junior studying interdisciplinary health sciences, and I'm an undergraduate researcher in Dr. Zainab Madakar Dogan's lab. And I have been an RU Inclusion Fellow since June of 2021, and that ended in February of 2022. And I'm continuing on this semester as a spin intern until June, where I will revert back to becoming an RU Inclusion Fellow. My project's title is Reserving Racial Health Disparities by Using Advanced Statistics and Machine Learning on Complex Multidimensional Datasets. So as far as the background of my project and an introduction, there are many disparities related to race and breast cancer. Specifically, in my lab, I study estrogen receptor positive breast cancer, which is a type of breast cancer that requires estrogen to grow. And when compared to non-Hispanic white women with estrogen receptor positive breast cancer, African American women experience later tumor grade and stage at diagnosis, earlier onset of that disease, higher mortality rates, worse survival, especially in estrogen receptor positive breast cancer, higher metastasis rates, have a higher incidence of breast cancer before the age of 40 years. They experience a difference in therapy recommendations. They're more likely to have had their breast cancer detected through symptoms, and also their breast cancer is more likely to be pairs, which means it's more likely to reproduce. Along with that, there is a lack of research done on African American women with breast cancer. So this certainly impacts their clinical outcomes. These disparities can be due to socioeconomic status, racism, health education and awareness, access to healthcare, and psychosocial, physical, chemical, and other individual and community level assaults that increase the risk of breast cancer. So over the summer, we used an MD Anderson dataset to show that African American women have distinctly lower survival rates when compared to non-Hispanic white women. And we also found that even when combination therapy is used, the disparity in survival rates is still present. So these results that compared survival and fulvestrant alone to combination therapy in African American women that are in the graph in the bottom left showed us that African American women have higher survival rates when combination therapy is used, and led us to our overall research question of, do African American cell lines expressing ER respond differently to fulvestrant alone or in combination? So my aim is to validate treatment response for fulvestrant alone and combination therapy in vitro using non-Hispanic white and African American cell lines. Our hypothesis is that African American cell lines will have a better response to combination therapy, resulting in better survival rates when compared to fulvestrant alone, and that non-Hispanic whites will continue to show higher rates of survival. We answered our research question by completing various experiments like cell dosage response, WST1 cell viability, drug combination response, and also by using data analysis and from there interpreting our data. On the right, you have a 96 well plate and a pipette, and that is a setup of my drug combination response and cell dosage response experiments. For this project, we study fulvestrant, which is an estrogen receptor degrader that results in accelerated degradation of the ER protein. Fulvestrant is a cancer drug that can be used alone or in combination with CDK inhibitors. And one of the CDK inhibitors that we use is called palbociclib, which inhibits the phosphorylation of RB, which blocks the cell cycle progression from G1 into S phase. So the typical dosage for both of these drugs is 10 to the negative 6 power. These two Kaplan-Meier curves under my results section of my poster show what I discovered in the summer, that non-Hispanic white women have higher probabilities of survival in general, and when combination therapy is used when compared to African American women. Below that, you see two photos of wells that show the cell growth decrease when you compare fulvestrant alone on the left to combination therapy on the right with palbociclib at the 10 to the negative 6 concentration, which again is the standard dosage. These cells are African American cells. Unfortunately, we have been running into issues with our WSC1 experiments, along with issues with the growth of our cells for each cell line. This is a graph of the African American cell viability, and our significant result shows that fulvestrant works at 10 to the negative 6 concentration when comparing it to our vehicle, which wasn't treated with any drugs. This result is known and expected, as it is the standard dosage used in healthcare settings on humans, and WSC1 is an indirect measure and therefore may not always produce accurate and significant results. So to produce better results, we are going to move forward with completing BRDU measures of cell viability, which is a more direct measure when compared to WSD1. Along with that, we will continue doing more trials and exploring our experimental options. And despite our troubles with our cell lines this semester, my project benefits the African American community tremendously, and our data supports the fact that African American women respond better to combination therapy when compared to fulvestrant alone. This will contribute new knowledge and information about fulvestrant therapy in African Americans, as there is an extreme lack of research on this area, and will help us as a society achieve equitable care for all minority groups. Moving forward in the future research on understanding the molecular mechanisms by which cyclids work on African American women with breast cancer should be done to determine why they work better. So thank you for listening, and I'd like to give a special shout out to the NCSA, the NSF, my PI, my PhD mentor, and Olena Kindratenko for their support. Thank you.